Resident in the Department of Gastroenterology, Surgery and Liver Transplantation, AIMS, New Delhi. He has served as assistant professor and head of the department Surgical Gastroenterology at SBIMS, Tirupati. He's a former assistant professor, Department of Surgical Gastroenterology at AIMS, Hyderabad, Bangladesh, Dhaka, senior consultant with Apollo Hospitals. Senior consultant with Apollo Hospitals in Colombo and Chennai. So sir has a vast experience and he's going to talk about a very, very important topic which we all are hearing to know, namely ERAS. Welcome sir, welcome to Kolkata. The stage is all yours.
Thank you so much. At the outset, I thank Ms. Sagamatra and the bigwigs of IAPN for this opportunity, and I should really congratulate you on your bunch of assistants, so very, very good hosts, I should say. Years ago, when I was working as a registrar in the All India Institute of Medical Sciences, Delhi, we were going on rounds, and the first question any patient asks is, Doctor Sahab, kya kha sakte hain? Then I often used to say, sab kuch kha sakte hain. I didn't know, I had no idea basically. One day there's a chap called Kohli, now he's a liver transplant surgeon in Mayo Clinic. He pulled me aside, I said, kabhi mat karo. Whenever patient asks, kya kha sakte hain, you tell this, sab kuch kha sakte hain, kintu anar ka juice kabhi nahi peena. I said, ऐसा कैसे यार? तेरा बात सुन. Unfortunately, I can't use this in Chennai because they don't drink Anarka juice there. That is the understanding we had. Now, nutrition has come up in a very, very big way. Actually, it started from those days in Delhi when there's one very pretty Sharma used to be there, who used to, do the nutrition part. All the patients there, including the ministers, they know only her name. They don't know the doctor's name actually. She used to be that popular and that friendly. Now, there are two things. One is, as Mr. Had been spoken by one of the speakers earlier, that if you are working in a hospital, no doctor will go in search of a dietitian. By and large, they're very busy doing their thing. It is the dietitian you have to go in search of a doctor and tell him or her that how can I help you. Once you start helping, then you get a lot of work, and the real essence of the dietetics comes into play. Otherwise, many hospitals, people do not know where the dietitian is actually, even now. So you need to sell yourself, and it's not the other way. Now, you are hugely involved in nutrition, in terms of post-operative nutrition and ICU nutrition and so on. But this term ERAS is certainly a new thing. ERAS is early recovery after surgery, because there were times when any patient used to stay for a long time in the hospital because of big wounds, pain and all that. But nowadays, there are many measures have come into play where patients go home very quickly, and any hospital's goodness or ability is measured by LOS, length of stay. And this essentially used to be a surgical anesthetic area of ERAS, early recurrent surgery, where anesthetists used to make sure that patient not have pain, and surgeons used to make sure that there's no big incisions are made. But then, in just recently, the importance of nutrition has come in a very big way, so much so that dietitians are getting into the nutrition part of ERAS, and that seems to play a very big role. And actually, in most hospitals, it is they who push this concept of ERAS. Now, I will not be talking anything surgical, because there are no surgical slides here. I am not showing any operations, but then I'll be going through some of the basic principles which most of the speakers have already spoken about. Now, enhanced recovery after surgery. ERAS is something which all of you should know, and whenever you see a patient, an operative patient in a hospital, you should understand whether the patient is coming under ERAS protocol or not, whether all the steps have been taken care of to send the patient quickly home with the least of any problems. And then one should understand that the ERA aims to improve surgical outcomes. It's a multimodal evidence-based approach integrating surgery and perioperative care. And that perioperative care, dietitian has a huge role to play. Nutrition, as I said earlier, is a cornerstone of ERA's protocols. It reduces complications and recovery time, which has not been known for a long time, and this is what is a recent innovation. Proper nutrition management helps maintain homeostasis and immune function. There's so many big words, but they're all related to nutrition, which is your area of expertise. Now, malnutrition, you should understand, is common in surgical patients and worsens outcomes that we all are aware of. And optimizing nutrition reduces infection rates and hospital stay duration. Now, this enhances recovery by maintaining muscle mass and wound healing. And early nutritional intervention addresses pre-operative deficits, because as I go on in due course of time, but most patients have already preoperative nutritional deficits that have to be corrected, and that the right people to do that is you. Now, what are the ERA's nutrition guidelines? Patients should consume a balanced diet preoperatively. Many patients don't do this. Actually, frankly, the only thing any patient is worried during the period of surgery or subsequent surgery is their diet. I've seen number of patients who have not taken non-vegetarian food for 1 year post some abdominal surgery. Why? Because the doctor didn't tell them. There are many who don't add haldi or salt to their food because the doctor, the grandma said that he should not eat that, and they continue doing that. It's unfortunate because a lot of these patients don't get to see dietitian subsequently. Now, one need to, according to the ERA's protocol, one need to avoid prolonged fasting and introduce carbohydrate loading, which is talked about by Dr. Vijay Kumar in the morning. And they need to resume oral feeding within 24 hours post-operatively. Any patient actually in our unit, we make sure that they get to eating normally by mouth at the earliest. There's no prolonged fasting. Now we need to tailor nutrition to individual needs and surgical types. Now, traditional prolonged fasting is no longer recommended. Still, there are hospitals where the nurses are not aware of the ERA's protocol, and they say nil oral from midnight, which is not the right thing to do. Is being done away with. ERA's protocol suggests a 6-hour fast for solids, that they can have solids up to 6 hours prior to surgery, and 2 hours they can have clear fluids 2 hours prior to surgery. This mechanism will reduce insulin resistance and enhances metabolic recovery. And we do use carbo load. Carbohydrate-rich drinks improve energy reserves pre-surgery. If it is not being used in your hospital where a large amount of abdominal surgery is going on, you should be the one who introduce this. You should be the one who tell the surgeon the importance of carbohydrate overloading prior to surgery. Now, carbohydrate drinks, they reduce catabolism and post-op insulin resistance is proved beyond doubt. They also enhance glycogen stores, promoting faster recovery. Now, this strategy is especially relevant to major abdominal surgeries. Now, what are the contraindications for carbohydrate overloading? One is diabetes. Even diabetes, in a moderately well-controlled diabetes, this carbohydrate overloading can take place. But then there are certain other high-risk patients where we avoid this. Now, you're all experts in this area where all these patients need to get nutrition screening, and you need to identify high-risk patients who can have problems post-surgery. And of course, you know what are all the nutrition risk screening tools that are available. And when we need to address deficits with oral supplements or enteral nutrition, and this is very important because quite often you get to see the patient only after the patient is admitted. You don't see the patient from the outpatient department and take the nutrition. You should be in good terms with the physicians and surgeons so that these patients are seen by you even before they are planned for surgery. And actually, several cases may require parenteral support as well. Now, immunonutrition has been talked about much, and that is also a part of ERA's protocol, and that includes arginine, omega-3 nucleotides. And this immunonutrition to this patient reduces infection and improves wound healing, and there is a lot of proof for that. And this immunonutrition supplementation should take place for at least 5 to 7 days prior to surgery, and it's actually commonly used in gastrointestinal surgeries. Now, post-operative feeding, as I said earlier, early oral feeding enhances bowel function and recovery. You need to push and you need to go to the post-operative ward and find out what the patient has taken. If the patient is nil oral for more than 24 hours, you have to talk to the treating team as to why food was not started. And you should be the ones who would push ERAs in these areas. You have to start clear fluids within hours after surgery. Actually, there were earlier the belief that there should be bowel sound, the patient should pass gas, there's no more held in repute, and patients can start clear fluids within hours after surgery because the small bowel will still be moving. And you need to gradually transition to a regular diet based on tolerance of the patient. It's actually patient tolerant. If the patient feels full or uncomfortable after oral liquids, you should slow down. But otherwise, the patient is comfortable, there's no issue. Patient having anti-resection, where rectal surgery, patient have a normal diet on day one actually, and they don't seem to have any problems with that. We need to avoid unnecessary parallel nutrition unless indicated. There was a time when the dietitians are not involved in parallel nutrition prescription, but they have also got involved in a big way, and in our hospital also parallel nutrition is maintained by dietitians. Now, protein supplementation is important, has been talked about again by many speakers prior to me, and protein is critical for muscle maintenance repair, and ERAS recommends 1.2 to 2 grams per kg per day of protein. Whey and casein supplements are effective options, and they should be given in the immediate post-operative period. Well, then we need to tailor all these depending on the patient's renal and liver condition. Now, micronutrients, another thing that we talked about, which is again not found in normal foods, regular foods, and also any of the supplements. Vitamin A, C, and E are to support immune function and healing. Zinc and selenium have roles to play in tissue repair, and these micronutrients address deficiencies preoperatively for optimal outcomes. And use balanced multivitamin supplements as required. Now, hydration is another important aspect of ERAS, which quite often many treating physicians overlook. Proper hydration prevents post-operative complications. You should also have an eye for this hydration. You see whether the urine output is good, whether the patient's tongue is wet enough, and so on. If not, you should talk to the concerned treating doctor and talk about hydration. You should avoid fluid overload to minimize tissue edema. Of course, electrolyte balance is critical for homeostasis. All these areas are as important to you as to the physicians. You have to keep these in mind and follow them up. If you don't follow, nobody's going to ask you to do that. You have to do it yourself, and you have to have your own chart saying all these are in proper position. For some reason, if you find the sodium is low and treating doctors have not noticed it, you have to talk to them and get it corrected. And of course, goal-directed fluid therapy is something that's been talked about quite often. Now, in high-risk patients, some of them require specialized nutritional interventions. We need to consider enteral parenteral nutrition in malnourished individuals. We need to monitor metabolic and inflammatory markers very closely. And you have to collaborate with a multidisciplinary team. You should be a part of a team. I often see that the dietitian assistants, they do their own rounds. They can do their own rounds, but at least once a day you should do rounds with the rest of the team, the doctor team, the nursing team, because it's something, unfortunately, there's no communication between doctors and nurses as far as nutrition is concerned. And there are many places where there's no even single day discussion between the dietitians and the treating doctors. Very important that all three of them have to have a direct communication channel, or at least once in a while they sit together and discuss the nutrition aspects of this patient, because you understand that over the years it's been proven beyond doubt that good nutrition gives rise good results, and you have a very big role to play. Now, there's a role of fiber in recovery as well. Fiber aids in restoring normal bowel function. It avoids you need to avoid fiber supplementation immediately post-surgery, because immediate post-surgery fiber may not be able to be digested. You have to go slowly, and we need to gradually reintroduce fiber into the diet to prevent ileus and discomfort, and you have to encourage natural resources like fruits and vegetables. Patients must understand the importance of peri-operative nutrition, and that start with pre-operative counseling, which includes patient compliance. And we need to use visual aids. Actually, as surgeons, for everything, we show a small video, we'll show some drawn pictures, we show animation, because this is how it is, and I'm sure all of you are doing it. because digital media come in such a strong way. Each one of you preferably should have your own video record on YouTube and put them so that the patient go back home and look at it again. Not just what the first consultation they have with you. You all should have your own videos on the internet, and that is a very strong thing to send the message to the patient. The patient will tend to go and look at your videos once in a while to understand what is new and what is not. And of course, we need to include other caregivers also in education process. All the treating group should sit together and exchange pleasantries once in a while, have coffee together, and see how we can educate each other. It's always felt that the higher ups will teach the middle level, and it's not so. There's so many things which the doctors learn from dietitians, the dietitians learn from nurses, and so on. There shouldn't be any gradation there. What are the barriers to implementation of ERAS protocol? One is lack of awareness among healthcare. Many of us do not know that surgery and post-surgical stay can be cut down by 3 days, 4 days, just by following these principles. That will reduce even the patient spending. And of course, there are limited resources in certain healthcare settings where it's not possible to follow many of those ERAS protocols. Patient non-compliance due to cultural or personal preference at another factor. We need to address these barriers with training and patient engagement. Now, what are the benefits of nutrition protocol? Reduce surgical stress, improve recovery, lower rates of complications and hospital readmissions, enhance patient satisfaction and quality of life, and is very cost effective. I am for one, we propagate daycare surgery in a very big way. Majority of the laparoscopic surgeries in the abdomen are done as daycare. Patient comes in the morning, goes back in the evening, which was unimagined some years ago, and this all thanks to ERAS protocol and understanding the physiology better. And as I said, dietitians have a role to play. In a patient 65-year-old male undergoing colorectal surgery, when ERAS protocols implemented in him, including carbohydrate loading and early feeding, patient's hospital stay shortened by 3 days and there were no complications. The conclusion is there is good evidence to support ERAS principles in real world scenarios. What are the future directions? We need to do research and personalized nutrition protocols. This personalized medicines come in a big way, and I'm sure personalized dietetics also will come a big way. Advances in immunonutrition and gut microbiota optimization has to be done. Integration of digital tools for patient monitoring is yet another advance in ERAS which has to be really closely looked into. Well, then this ERAS principle should be expanded globally. And in conclusion, ladies and gentlemen, perioperative nutrition is integral to ERAS protocols. Avoid prolonged fasting, prioritize carbohydrate loading, early oral feeding, enhance recovery, multidisciplinary teamwork ensures success. Thank you for your attention. Thanks for this opportunity.